everyone. Good morning. It's such a pleasure to be with you here today. I'm Dr. Katerina Paraskevas. I'm an active and proud member of MARCOM. At this time, I would like to introduce our next speaker, Dr. Marianne Cloeren. Dr. Cloeren is an associate professor of medicine in the Division of Occupational and Environmental Medicine at the University of Maryland School of Medicine. She serves on the Maryland Medici Opioids Pain and Addiction Committee and the University of Maryland Medical Center Opioid Safety Council. She works on multiple research projects addressing the barriers to employment faced by adults in recovery from opioid use disorders. These projects focus on the intersection of work and recovery with support not only for patients, but also for employers. The projects also serve an interprofessional purpose, as partners include scholars and stakeholders from medicine, social work, nursing, pharmacy, public health, law, business, and epidemiology. Please welcome Dr. Cloeren.
Hello, everybody. I'm hoping my voice will make it. Luckily, I don't have much time, so hopefully it'll carry through. So I'm happy to be a Northeasterner because that means we talk fast and you guys can listen fast. I'm probably gonna skip through some of my slides because I think I probably have more slides than we can really get through. But wow, let's see this. So these are the objectives. All right, enough said. I do want to mention that I have a partner in this work who's a professor in the School of Social Work at the University of Maryland. She's my co-principal investigator. You know, research was kind of new to me. I joined the faculty at the University of Maryland in 2017. And, you know, I came there kind of on the strength of teaching, but hadn't done a whole lot of research yet. And Jody Fry in the School of Social Work has been kind of a mentor to me, even though she's significantly younger. But some of the projects that we've worked on together have all kind of been at the intersection of work and health, but specifically around opioids. The project that I'm talking about today is we call it. I decided that I really like the idea of Framingham. Raise your hand if you've heard of Framingham. Yeah. So it's got like branding, right? So I decided when I got started with this in 2019, that I was going to brand our project so that we become famous. And you know, we're not really famous yet, but we have managed. Like the acronym PROSPER has a lot of good letters in it, because P's and R's and O's, you know, are found in an S. You know, they're found in a lot of words, and so we actually have a bunch of different projects that use PROSPER, and in them, PROSPER means different things. It's really fun. We kind of like repurpose PROSPER. But Workplace PROSPER is partnering to reduce opioid stigma and promote employment and recovery, and so it's really aimed at the employers. We've had a few different grants related to this. Right now, we're working with the Maryland Department of Health. And like the vision is like everything in occupational medicine, you know, we try to affect the individual, right? But we also have to work with employers, and we're trying to influence changes at a societal level, right? And so everything we do, even if it has a worker focus, usually has other stakeholders in mind, you know, the employers, the safety professionals, the lawyers, the HR people, and then ideally policy and the government. And you know, so we have kind of a ambitious agenda. I've been through all that already. So our goals in Workplace PROSPER. I'm gonna skip that. So it's not just use disorder at work. You know, the last presentation, I think, gave you an idea. If you didn't already know, I think everybody in this room knows that many people with substance use disorders are at work, right? It's not all people who are disabled from their substance use disorder. And about 9% of employed adults are thought to have substance use disorder. Construction workers are at much higher risk than other workers. And I'm going to get into a little bit about why. This is just some of the research that has been published about construction worker risk. And this is specifically opioid use, opioid overdose deaths. You can see that 4 times, I don't remember how high in Massachusetts, but it was the highest In Ohio, 7 times more likely than other workers. The National Safety Council estimates that 1 in 5 construction workers has a substance use disorder. And there's also a syndemic going on with construction work in that they have a very high suicide rate as well. And I attended a workshop that was held by the Center for Construction Research and Training, which used to be known as the Center for Protecting Workers' Rights, and still goes by that acronym, CPWR, about that syndemic of suicide, high suicide rates in construction and high opioid use disorder rates. And they're related to each other, aren't they? The things that affect people that wind up resorting to suicide are often similar risk factors that wind up causing substance use disorder. And so if you can get to the root causes, you might be able to impact both of those epidemics. So why construction? Some of it probably has to do with musculoskeletal disorders from work. We have found, I'm actually getting ready to publish something looking at prescriptions in different workers in different industries. And construction workers are getting more opioid prescriptions for minor injuries than, I hate when it does that. They seem to be getting more prescription opioids for minor injuries than workers in other kind of industries. And so some of it is probably something that we can influence as physicians. We're seeing that increase, from 2011 to 2018, overdose deaths increased 9 times, which is outrageous. In Maryland, construction workers make up about 8% of the private workforce, and they have about 22% of the overdoses, opioid overdoses. So, and so that was kind of, that wasn't really rates, but we did have the opportunity through this grant to look at the state unintentional overdose reporting system. There's the TBC has this registry of overdoses, and I think pretty much all the states participate in it. But we were able to get the Maryland data, and our research question was, do opioid-related overdose death rates differ by industry throughout Maryland? The sample was 21-23 overdose deaths, and this was 2018 data. Most of the overdose deaths were in men. The majority was white, followed by black, and almost 100% were working age. And if there was industry information on the death certificate, so this data really relies on what is found in the data, right? And a lot of times industry information is not there. But if it was there, we were able to analyze it. And we published this just this year, or end of last year, this year. What's the date? I don't remember. In JOEM actually, but we found that construction workers had, the rate in construction was 212 deaths per 100,000 construction workers. That's super high. I don't know if do you guys remember when Baltimore was in the news for having really high overdose rates that were not being publicized? The Baltimore Banner published something with the New York Times, I don't know, maybe 4 or 5 months ago. And the overdose death rate in general in Baltimore, it's apples and oranges, but the overdose death rate was something like 71 per 100,000, which was really, really high. Construction went 212 per 100,000 construction workers. Manufacturing was also high at 99 per 100,000, and transportation and warehousing also had unusually high rate. And don't quote me on this, but I think if we averaged out all the workers, it was something like 35 per 100,000, so it was much higher. So why are we seeing this? About 15% of workers who are prescribed opioids become long-term users. Now, if you're a long-time user of opioids, that doesn't mean you're going to become addicted, but it does increase your chances, right? And so long-term users have 10 times the risk of becoming and developing opioid use disorder. Also, most construction workers don't get paid sick leave. Did you know that? Anybody here work with construction work? It's interesting, no paid sick leave. Many of them don't have health insurance. I'm gonna show you a weird slide coming up. I'm gonna go into that a little bit more. There's also high demand low job control, there's not a whole lot of social support, there's very high stigma. And the culture really, at many male-dominated industries, the culture kind of discourages help seeking. And I think some of you are probably familiar with that information. Our preliminary workers' comp data shows that, that opioid prescribing did decrease. You know, does anybody remember when the Maryland prescription drug monitoring program went into place? When did all the opioid controls start to go, on prescriptions, when did they start to go into effect? Anybody remember? 2010, yeah, between 2010 and 2014, that included prescription drug monitoring programs. It included physician education, you know, a lot of focus on the physician contribution to this problem. And so prescriptions did go down, but as I mentioned before, opioid prescription rates are higher for minor injuries where they're not indicated. And we're getting ready to publish this. These are the groups. Again, so it kind of relates, it relates very well to what we're seeing in overdose deaths. Potential root causes, I'm just stick these up here. But all of these things are a problem. Some of them don't have health benefits. You know, if you're a construction worker and you belong to a union, usually you have, you know, decent health benefits. But even in unions, you may not understand how to access them. There may be many different kind of plans. So even where construction workers are represented by a union, it may not be as easy to get the help that you need. And then of course, if you're not union, you're less likely to have the benefits. And about 20% of construction workers are self-employed. I'm gonna tell you, my stepson is a self-employed construction worker. He's not in this state, he's in another state. He's a painter, you know, he paints apartments. I don't know why he decided it'd be better for him to be self-employed, but what this means is he gets his work through one person gets the contracts, he funnels the work to my stepson. And the person that gets paid, you know, for the work, takes something off the top to funnel it to him and is not responsible for anything for him. Like, there's no health benefits, there's no time off, there's nothing. And he's not paid, he doesn't get paid enough to have healthcare. So he has not purchased healthcare. He did it for a little while and then he couldn't afford it. If you're self-employed, do you have workers' comp? No, right? And he doesn't get any paid time off. So if you have a work injury and you don't have health benefits, you don't get paid time off, and you don't have access to workers' comp, and it's like 20%. How are you gonna get through your workday? How are you gonna feed your family? And so I think that's part of the reason there's some of the pill sharing that we see in construction work, and some of the use of opioids is to get through the workday, and then a subset, you know, wind up addicted. So these are, you know, some of the issues. So nationally, all right, raise your hand if you heard of drug-free workplaces. You know, like everyone's heard that. You students better raise your hands, Jen, did I mention it? Okay. And so when this went into place, there was widespread drug testing, right? And also employee assistance programs came about as a result of that. So that's fine. You know, we're gonna test everybody and, you know, send them for help if they need it. Typically kick them out maybe if they're caught. How this often works is if you ask for help, we'll help you, but if we catch you with a drug test, you're out. And so, you know, one of the problems with substance use disorder is you don't necessarily have the best judgment around asking for help. You know, part of the illness is you don't necessarily have the insight to ask for help. So anyhow, drug-free workplace was the first phase, and then that sort of led to the whole zero tolerance. And more recently, the see no evil, you know, where now that cannabis is so legal, a lot of companies are not testing anymore. And when employers were having trouble kind of filling their slots because the unemployment went way down, and it became kind of a struggle to hire people, a lot of companies just kind of stopped testing because they'd rather not know. There is a new trend, and I'd like to know if you've heard of this. Who's heard of recovery-friendly workplaces? Anybody? One, okay, anybody else? Two, three, great. It started in New Hampshire, it was kind of a state, initiative, and, oh gosh, maybe 10 years ago. And a lot of other states and jurisdictions have adopted it, the federal government is hopping on board. But basically, the idea is to provide support for those in recovery and to, try to provide, peer programs and try to, to reduce stigma and to recognize that substance use disorder is an illness. It's not bad behavior to be punished, okay? Now, it can lead to bad behavior that may need to have, consequences, but the condition itself is an illness, right? And so Maryland now has a recovery-friendly workplace pilot program, and we're very lucky to be working with the Department of Labor and the Department of Health to, okay, wait, I went through those already, to try to get this some momentum in the state. These are, if you go to the slides, each of these should have a link, and so you can read more about them. The first one is the New Hampshire kind of model. The New Hampshire model is kind of interesting. Basically, if there's enough state support that if a company wants to sign up and become a recovery-friendly workplace, they're assigned a consultant that kind of gets paid through the state, kind of a contractor, to help them develop the programs, develop the policies, to, put into place the stigma reducing training, all that kind of stuff. But they have to kind of sign up for all, like, it's like an all or nothing kind of thing. It's like, you gotta pledge that this is gonna be your culture. NIOSH has some information about it. NIEHS has some, had a really good report just kind of talking about nationally, how much are we seeing, and not much really. There is now, the Department of Labor has a recovery-ready workplace resource hub. There's several different, NIOSH calls it workplace supported recovery. The Department of Labor calls it recovery-ready workplace. Everybody puts their own kind of spin on it. But there's now a National Recovery Friendly Workplace Institute. What we decided to do in Maryland is to not make it an all or nothing thing. And that's the link to the Maryland one is in that last one there. Not to make it all or nothing, but to have kind of a tiered approach. And so if employers want any part of it, the Maryland group will work with them. So if all you want is naloxone for your workplace, fine, it's a foot in the door. Let's get you started with that. And we're hoping that having this kind of a tiered approach with not necessarily committing to the whole shebang, will get people more interested in it. So some of the predictors for substance use disorder treatment success include having strong support systems, having access to comprehensive treatment programs, but also to have beneficial employment. Which of these can employers promote? Which ones are kind of in the realm of influence of employers? You can shout it out, what do you think? All of them. Yeah, so, trying to make sure that you are not excluding people that are in recovery by having kind of arbitrary screening that excludes people that may have a problematic past that are now in recovery. That would be one way. Access, your benefits programs. I mean, we've done surveys of employers, and a lot of employers, and these are like HR people, they don't actually know, they don't know whether their benefits programs include treatment programs, like inpatient or outpatient treatment programs for substance use disorder. They know about other benefits. And then strong support systems. There are companies, like Amtrak has a peer support program. There are big companies, and there's a movement toward having peer support. I don't know if you know what peer support is. Peers are people with lived experience who are in recovery who can act as a conscience, maybe like Jiminy Cricket, but also a resource for people that may be struggling, somebody that you can trust more than you might trust your HR people. Like if you can go to somebody that has had the same struggles that you're having right now, people are more likely to do so. So some companies are putting into place peer support programs, and that's part of the recovery-friendly workplace model. The definition, or one definition, I'll let you read it, I'll read it out loud. It's pretty cool, isn't it? And it's something that a lot of employers could kind of get behind, in theory at least. Department of Labor describes it this way, facilitate help seeking, expand opportunities for people in recovery, reduce risk, help your supervisors know what to do if they're suspecting this in somebody, right? Because I think a lot of times what happens is you just sort of, you let it stew until push comes to shove, and then you send somebody for a fitness for duty, and then you have a drug test and it shows that they're using, and then they get kicked out. And how is that good for anybody, right? And then when there are clues, that if supervisors were kind of prepared with, how to manage it in a different way, they could help people. All right, so, so they're thinking about, this was one of the surveys we did. We didn't get that many responses. We didn't publish this yet. But you can see that what people have in place were kind of leftovers from the drug-free workplace programs. Referral to EAP was pretty high, and drug testing was pretty high. Not a whole lot of people were actively doing anti-stigma training or have Narcan for overdose. Now, for those of you that work, raise your hand if you work like directly with employers. Okay, a lot of you do. Do any of your employers have Narcan programs in place yet? One, okay, two, good. All right, yeah, it's starting to take hold, which is great. We're considering the naloxone program's a foot in the door. That's like a little graphic for a foot in the door. We think we can start working with employers on naloxone, which they kind of, it's not that threatening. Like they have AEDs, they have first aid, they have people that will respond to emergencies. And one of the ways that we have gotten buy-in on naloxone is, other people that are not your people might wind up at your workplace and might need help. And so for employers that interact with the public a lot, that might be a way to get them to agree to have some kind of naloxone program, like hotels, restaurants, places that interact with the public a lot. But also, so how does that work with like transportation and warehousing? That argument may not work as well. But we're finding that there is openness to it. One of the challenges with naloxone is it's over the counter now, right? But it's not that cheap, right? And so if you're going to be providing it to every employee, that's a stretch. So we had a grant with Maryland's Office of Overdose Response that went July through the end of June this past year to try to get more naloxone into the hands of construction workers in Maryland, because construction workers had the highest risk, right? And so our goals were to engage the Maryland construction industry, and we wanted to use an academic detailing kind of an approach, just talk with them about the problem, see if they're interested, right? Try to connect them with the naloxone training that was provided by the state. The state had all kinds of overdose response programs scattered all over the state. And they're usually in different, community kind of things, hundreds of overdose response programs that'll do naloxone training for the community and provide naloxone. And so our initial plan was to connect the construction employers with these overdose response programs in the community to try to coordinate the training and distribution and, to get naloxone into the hands and to document the barriers. And so we did this initially, because I'm stupid, with cold calling and just kind of like, random. Yeah, how far do you think that went? Okay, so we were spinning our wheels quite a lot. We were documenting lots of barriers. But we also met with people. Well, we recognized the need to kind of get with the industry. And so we started to go to construction safety conferences, and dang, that was wonderful. So we joined up with the Maryland Center for Construction Education and Innovation, and they invited us to a meeting where we did naloxone training for all these representatives there, and we gave them naloxone, and we signed them up, and they were interested. And then CPWR, and then we're trying to work with the unions. That was actually kind of challenging. ABC, which is the non-union kind of side of construction. You know, these are all our different partners. These were our goals, blah, blah, I talked about this. So, you know, our guess is it didn't really work with cold calls, right? But the presentations at construction safety events did work. And we had so many construction safety people say, yeah, we're really interested. But it's just our champions were really the construction safety professionals. Now, we pivoted in our plan and we developed a train the trainer program for the construction safety professionals. And so far, we've trained about 100 construction safety professionals to be trainers through us, and they're doing naloxone training for their workplaces and getting out naloxone. They're not paying for the naloxone. I think that was a key thing. We set ourselves up as an overdose response program that is employer facing. We're the only one in the state. I don't think that Rhode Island maybe does it. It's kind of unusual across the country. But we set ourselves up as an overdose response program that is employer facing, which means that we can train trainers, and we can get naloxone free from the state and distribute it to at-risk people, which includes people in the construction industry. So we've given out, actually, it says 3,000. We've given out about 5,000 naloxone kits to construction workers through this project, which is really neat. And they're starting to integrate, some of the bigger ones are starting to integrate it into their plan so that they're figuring out how to do it ongoing, kind of without leaning on us. These are the kits that we put together. You know, when we get it from the state, it's just the box of naloxone. It's 2 naloxone, two naloxone doses. And but the safety guy said, yeah, you're expecting us to do mouth-to-mouth resuscitation if somebody's not breathing, you know, without, you know, so we through our grant, we got the face shields, you know, disposable face shields. We made little stickers for hard hats because apparently construction guys like that put stickers on their hard hats. So when somebody gets trained, they get a sticker for their hard hat, we put gloves in it. And we also had instruction cards. We developed construction cards in both English and in Spanish. And we have a whole Google Drive full of construction focused training materials. The training is in video format. It's in video format that they can include in their own training that they're doing at their work sites. It's online, it's slide decks, it's toolbox talks. You can see this is one of the trainings that we actually did. And those kits we have, they're assembled actually by volunteers. We've got lots of volunteers at the university that are coming to my office and putting together the kits, which is pretty neat. I asked them, what does the construction worker do? And you'd be surprised. Well, actually, I learned a lot about construction work through this project. So you have a big idea, maybe, that they build things, right? They lift heavy things. Right. So who does the construction worker work for? We talked about the 20% that are self-employed. Who do the rest work for?
Companies.
Okay, what kind of company?
Contractors.
What contractors?
Companies that hire construction workers and also the contracts to do the work with the people who want the building done.
Okay,
So they're intermediaries.
yeah, right. It's complicated. It's a very complicated industry. So, you know, there are contractors that are involved at the site preparation stage, you know, so there are demolition contractors, there are excavation contractors, there are paving contractors, there are foundation contractors. And all of these are different companies, basically. And then there are people that do the framing, and then companies that do the carpentry, and elevator constructors are their own companies, and roofing companies, and then there are the ones that do the inside, the pipes. And then, you know, ones that make it pretty, right? And each of these is like usually a different kind of contracting company, a different trade contractor. They're not the ones usually that are working with the people that, they're not usually ones that get the contract, the top level contract. So there's usually general contractors at the very top, and those are the big, you know, the signs you see out there, Clark Construction, White and Turner, and all those big companies. They're the ones that usually get the big contractors, and then they hire the subcontractors, you know, the trade contractors, who may or may not work with unions. And like ABC is the merit shop, the biggest, I think, of the so-called merit shop side of it, which is basically that they don't work with unions. And so it's a trade association. They've been wonderful partners in this. We do trainings with them, but I don't know what percent, but the majority in Maryland at least is not union. NAB2 is North America's building trades unions, and it's kind of like, it's not even national, it's international, because I think it's Canada, maybe Mexico too. And each of the trade unions is kind of, has national representation, and to get to the Maryland ones, we had to try to figure out, which trade, who are the contacts, and we had to kind of go to the national level to get down to the Maryland level, and there's lots of secret handshakes in the union. Anybody work with unions? Like, you gotta know people, and so it's been really fun, and we actually had more success on the non-union side, even though the unions are very, very interested in this, just making the right contacts and finding the right people in the unions has been challenging, but we're working at all levels of this. And then CBWR, the Center for Construction Research and Training, kind of works more on the union side of things. They work on, they're not restricted to that, but they largely work with unions. So I want you to get ready for a really convoluted graphic that I use to try to explain why this is so hard. And also, like, why do we have to give naloxone? Why does the state of Maryland have to give naloxone to these big contractors? Can't they afford to buy naloxone for their own employees, damn it? Who's thinking that? Isn't it their responsibility? Well, okay. So I apologize, but you see all the way at the top, there's a general contractor, right? And the general contractors, they may be big, they may be small, but they're basically the ones that get the contract. And the ones that we're working with are usually the bigger kind of companies. They usually have their own safety teams. They have their own safety professionals. They've got a bunch of other managers. And they're going to manage lots of different construction sites usually. At a construction site, they're going to have when I made this, I forgot to fix it. I called it a site manager, but I learned later it's a project superintendent. So at a site, they're going to have a project superintendent who's managing the work of all the different contractors. And it kind of depends on the phase of the work, what's going on. Is it excavation, is it carpentry, is it, whatever. Some of the contractors, some of the trade contractors, like the asphalt company, they may be big enough that they have their own safety professionals. And so the ones in red are basically, we're trying to grab safety professionals in construction at every level. So we're working with the safety people, the general contractors, with the trade specialists, with the trade companies if they have one, if they're big enough to have a safety specialist, and then also through the labor unions. Labor unions are mostly training apprentices, people that are kind of like brand new learning the trade. They don't have a lot of involvement training wise with people that are out in the field. And so we're trying to reach the trade, the construction trade companies that are hiring unions, to do that with them. But then you'll have that, see the dotted line box there? These are the temporary hires or the self-employed people, and who's responsible for them? The general contractors may have thousands of people that are not their own people kind of migrating through their work sites in a year, like thousands. And they may have, like, people may be at their work site for a couple of weeks, a couple of days, a couple of weeks. And so are they going to buy naloxone for every person that comes through? And so just trying to figure out the logistics of how to get the workers, these people at the bottom, the people that are doing the work, the people that are at risk, how to get them trained has been really hard. And so you may say, why not just stage naloxone all over the work sites? That's a good idea, isn't it? Make it available, put it in the porta pots. Put it in the medical trailers, have the people that respond to injury, they respond to first aid, carry it with them. Absolutely, that's definitely needed. Where do most of the overdoses among construction workers happen? Off-site or after work, yeah. So off-site or, and they may be hanging out with other construction workers, but they're not usually, it's not usually while they're at work. So having it available at the work site is very important, but it's not enough. And so we're making the point of getting it to them. What we're finding, which is just really exciting, is that by making the naloxone available and making it easy to do the training and get the naloxone, all these, like pretty much everybody that we've contacted, they're all over it. They're integrating it into their orientation training for people coming on site. They're making it part of their operations. If they don't have to figure out how to buy it themselves for everybody, they're figuring out a way to get the training done. And, you know, we're expecting like tens of thousands of doses to be distributed through this to construction workers. So it's really very exciting. So we talked about this a little bit. They don't have sick day. Even the ones that, have health insurance usually don't have sick days. Union guys usually don't have sick days, which is nuts. And so this is a wicked problem. You know, we're all public health people. You heard of wicked problems. So this is a wicked problem. There's like multiple and conflicting interpretations of the problem. There's a lot of, you know, anyhow. I don't know that we found the solution, but I think it is a solution. And we're also, we're using our contacts in the construction industry, to also start working on the suicide problem. And we have a new project where we're going to be training construction. We think we're gonna go with foremen, because they have more, day-to-day interactions with people than maybe the safety managers do, to learn how to recognize somebody at risk for suicide and how to talk with them. So we're gonna be doing joint naloxone training and, suicide response training. So there's a white paper, blah, 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 blah. I talked about that. We are also working on, trying to figure out, you know, we have all the stigma, and so even if we could figure out how to address the stigma, how do you manage to do it with such a labyrinthine organization? Like it's such a crazy organization. We think that there's probably gonna be a big potential role for peers, you know, people with lived experience, and so we're looking forward to studying that. And these are some of the citations that I did in time, and I didn't lose my voice. There's maybe time, I guess there's time for a few questions. I do wanna say that during the break, which comes next, there are student and resident posters in the room next door. Please, if you're a student or a resident with a poster, stand up. Yeah, stand up, stand up. Stand up, stand up, stand up. All right, great, thank you for being here. Please go visit them, talk with them about their projects, and I'm happy to entertain questions if we can.
Can you guys stand up, keep standing up, who had that? Please. How many of you are students of Dr. Cloeren? And Maggie's not here.
His car was hit on the way here.
That's why I said you were part of the planning committee.
Oh.
Cause you guys are the future of Ahmed. How many are the second year working with Dr. Cloeren? Anybody? Right? So you're the ones who are gonna be telling, the first years are gonna be telling people, but you gotta take this class. Cause Ahmed is a great specialty, but we don't do a great job of promoting it. But you're our best promoters. So you guys are more than welcome in ACOM and MARCOM, and you can ask anybody around here if you ever need anything. You will never be told no.
Unless you skip class.
Are there any questions for Dr. Cloeren?
Would you microphone?
Question. You touched on what you slide about people being, you know, as providers looking for, you know, in an office like substance abuse and people suspicion. I found that pretty tricky because how do you approach, who do you talk to, and what if you're wrong and you sort of insulted the peer or the worker?
Well, and so, I guess I already heard that question. There is an art to it, right? And I think that the conversation comes from a place of concern. You know, I've noticed blah, 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 you know, and just kind of calling it, I've noticed blah, blah, blah. What's going on? You know, how can we help? So, I mean, it's too complicated, you know, for an answer here, but there are training programs around it. So are you talking about suicide in particular or substance use?
Both.
Yeah, I mean, I think either way, it's learning how to have a conversation with someone.
Are there courses that are there physician training courses that you recommend or?
Well, this training that what I'm talking about is really for the people that are working with the workers, not so much the physicians. Right? I mean, by the time the physician sees them, somebody's already suspected something and gotten there, right? Unless you're talking about somebody in your own,
Yeah, workers in the office, staff members that come in, you know, I've seen it.
maybe everybody needs this training. Well, that's the whole thing with the recovery family workplace movement. Is part of that training is how do you approach someone that may have a problem, in a way that at least opens the door for them seeking help. And they may not seek help right away, you know, but you've kind of named an issue. I think there's another question back there first before you talk.
Thank you. I was wondering if you knew what the demographic, of course males, but in terms of like are they married? Like, are they, just to better understand? And the second part is, do you have like a database of like comorbidities? I'm just curious, what else is,
Yeah.
besides musculoskeletal disorders, like what else is common in this population?
No, we don't have such a database. And the pseudoers data, I don't know if we did not research the question of marital status. It might have been in there. I think it has been researched, and not being married, I think, is a risk.
Yeah,
But I believe it wasn't one of our research questions.
sorry, just curious.
Yeah, it's a good question. Yeah, Carl?
I'm involved with the New York, workplace recovery, effort.
Mhm.
And they are leery of physicians. And I don't know if that's true across, because every state is gonna be different, every program is gonna be different. But I think it's very important that physicians get involved in these, because I think there's a lot of misunderstanding about issues of substance abuse and risks and recovery
Mhm.
among those in the community itself who are living it every day. They see something quite different than I think we see at a more macro level.
Yeah, I think that's a good point. And if what they know of the position is you're the one that somebody gets sent to get kicked out of work, you know, I think we need to have a different, a broader role. I think we're probably over time. We probably need to.
Tanisha, do you wanna?
Just a real quick comment. So I saw you have the National Safety Council up there, and they actually approached ACOM to support them in some of their initiatives to get naloxone in workplaces.
Oh,
And I was surprised by some of the resistance that we got. I'm in a hospital setting, so it was like a no-brainer to us because we're in
Yeah.
clinics, but the corporate folks were saying they're worried about liability, even
Yeah.
with Samaritan laws, with the interface with the public. And then also just the supply, making sure that they have updated supplies in there, and then the training was the big things that they cited for us.
that's interesting. The employer resistance, there is some mythology about naloxone liability that is coming from the general insurance industry. It's not workers' comp, it's not health insurance, it's the umbrella insurance people, and maybe ACOM could approach that industry. I think that would be that would be a great service. The training is not hard. I mean, it's not hard to administer it, so I don't know.
Marianne?
Yeah.
One question. The biggest resistance I've seen in construction work is anything that's gonna generate OSHA 300. If naloxone can be considered first aid and not generate an OSHA 300, you would have no problem with construction.
Well, we're not having any problem with construction. I don't think that has not come up at all, because it's not a work injury, right? You know, so, yeah, but that might, we have not experienced that with the construction industry, at least. You know, once they got a way to get the naloxone free, they were all over it. They've become great champions.
Thank you.